This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. Thank you for joining us. I'm Dr. Dino Prato, founder and CEO of Envita Medical Centers, here with Dr. John Oertle, one lead physician, works with me on the research and development. And today we have a colorectal cancer case that's really a nice case to see because it goes through different confirmations that we did in this care, and you can monitor. You can see the improvement in the patient clearly through the imaging and how they responded very well to care. But we'll take you through this so that you have a better understanding of our precision oncology with late stage and complicated colon cancers. This is a widespread case, and we'll talk about how this approach was helpful for this particular patient. So let's go ahead and get started here. Dr. Oertle, John, thanks for joining me. And as normal, go ahead and start taking us through the case, and then I'm going to jump in and add or talk about some of the nuances that are helpful for education.
Yeah, that's excellent. So this patient was 56 years old, and she was diagnosed with, you already said, colorectal cancer. This is originating in the colon. But this individual had cancer that literally had spread everywhere. So again, in the lymph nodes, in the bones. And so she looked at the current, again, she went to her oncologist, wanted to be able to recommend just the status quo, essentially just that cookbook guideline. This is what they recommended.
Well, let's take a minute here. I want to take a minute.
Radiation and surgical resection.
So you had FOLFOX, right? These are just acronyms for a series.
FOLFOX means that it's essentially it's a set of chemotherapies, 5-FU and oxaliplatin.
Right, which is a standard for colon. It's a first-line therapy. Right.
That's right.
With radiation, maybe to the bone and other regions, right? To act really either to try to eradicate the disease, but could be palliative too.
And this was external beam radiation, which I get concerned about as far as that goes because of the issues that go on when you do external beam alone. You're hitting, essentially what this does is that those radiation beams, it's something that's circulating around you, and it's hitting trying to be able to guide that radiation directly to the tumor. The problem is that radiation hits all the healthy tissues surrounding this. So when you have so much cancer and so deep in the body, it's hard to penetrate exactly where that tumor is located without hitting the tissue.
Yeah, even though the equipment has gotten better, right, over the years to be more precise, less sparing to the healthy tissue, it still can overtreat and actually block some immunotherapy depending on how it's done. And we'll talk more later. We have a process we work on that's called 3D tumor targeting. This case did not involve that, but where we use radioactive beads the size of a rice grain or a red blood cell, similar to what's seen with brachy, except where it's proprietary is the radiosensitizers around it to activate it to work better and longer and precisely place that again in an interventional radiology. But that wasn't done in this case. And also let me state that this patient didn't do any of the radiation because they chose to come to Envita because of the widespread disease and weren't happy with this conventional regimen that was offered that didn't have the comprehensive approach, even though we'll go into it here in a minute. Let me move to the next slide. I'll let you continue, John. Go ahead.
Well, this was her CEA antigen as well. So this is a tumor marker. Again, CEA is commonly elevated, not always, but commonly elevated in colorectal cancers. In this case, it was elevated at 5.3. We'll go into more details about that and seeing, but that was the original CEA response. Here's some of the actual genomic variants that we're actually see and monitored. We know we run a lot more as well, as we like to be able to say, but we're not going to exhaust you with this slide. And this is not the time or the place to be able to do our 1,500 hours of education of our medical professionals here at this time. But we do see a couple of pretty significant ones for colorectal cancer. And you'll see that these are DNA that should not be in the system. This is what's called cancer-free cell DNA. It's a blood test that's looking at cancer cells DNA that have been gotten outside of the cancer cell and now is floating around in the bloodstream. This is something similar to how many times when you're pregnant and you're running a blood test to see the genetics of the actual baby, you run the mother's blood, but you're seeing the baby's blood. This is similar to seeing that same process to be able to actually see the cancer's DNA floating around in the system, which should not be there.
Not unusual. You'll see this BRAF. It's not unusual to see that in a colon cancer patient, right? That's not an unusual mutation. And these mutations can be helpful partly in our algorithms for targeting, but also gives us something to look at as a leading indicator as we're looking at these genomics. Let's continue. So here's the image.
What that starts to tell me, though, as well, is that these are, when you look at those, these are starting to be able to say, what are those conventional options? What are the off-label use medications? And what are the actual natural agents that are going to be supportive, even just with those various, those mutations that are present? Okay, so this is the reason that this woman decided and elected to not go with the conventional system, because as you can see, this was the original image when we actually ran it. You can see that this cancer is spread to a lot of areas in the body. This is, even though that you're going to go with the first line, you want to be able to make sure that those therapies that are being recommended are actually, in fact, the right therapies. Because with this much cancer, you don't want to get it wrong. I always say that, right? You don't have many chances to get it wrong. You want to be able to have one shot to be able to get this taken care of.
Let me add that even if, and I go back to standard oncology, would have gotten, just by the NCCN guidelines, would have gotten the chemotherapy right, the problem is there's no immunotherapy, there's no adjuvant, there's no targeting. So it becomes, there's no metabolic targeting, which we know cancer is a metabolic disease. There's a lot that goes into Envita's algorithm. They wouldn't have gotten that. They would have gotten first-line therapy. In the same right, if the patient just decided to go to alternative medicine, they may have just gotten vitamin C or an integrative phytotherapeutic with no targeting. And the problem with that is both lack precision. So when I keep saying we're not alternative medicine, that doesn't mean we don't use adjuvants that are integrative, that are perfectly matched or best matched, or that we don't use conventional that are matched on and off label so we build the right custom plan. That makes all the difference. Again, it's about the drug, it's about the targeting, and what I've learned over the years, the combinations, the right doses, given in the right manners, and that's why we built the whole precision modeling. So let's continue here with what we see here in this patient.
Yeah, so this is just the impression from that image, essentially showing that it's in the colon, in the rectum, it's in the lymph nodes everywhere throughout the body. It's in
the lungs.
It's in the pulmonary. Yep, in the
bones,
the chest, and it's in the bones.
So that is a very
everywhere as the image is showing.
So that's a very serious stage 4 wild, disease, because it's in the bone, in the lungs, it's everywhere, right? So it's widespread. That's important. And so let's continue here. So then the treatment plan was built. The genetic information came in, all our bioinformatics were run, all the immunotherapy targets, adjuvant targets, all the data that we run is put in, and then finally a plan is built. So when you see this GTFC, it's not telling you exactly which drugs were used, or the immunotherapy is not telling you which immunotherapies were used. It's telling you the methods that we selected, and then how those are combined and given to the patient. So Dr. Oertle, John, continue on as we go through this case.
Yeah, in this case, so it's actually really interesting in this case. So 90% of our patients that we see at Envita are on the wrong chemotherapies. It's not even the wrong dosage. It's actually causing harm to the body, and it's not doing a single thing for the cancer. In this case, this is part of our 10%, that the actual recommended FOLFOX, that 5-FU oxaliplatin, was actually showing to have some therapeutic targets to this actual patient. Not all the therapeutic targets, but why is that different? Because we did use some of those agents in our GTFC planning, but what was really different is that we didn't use the same dosage. And this is where when you use them in those high doses, they cause a lot of side effects and they suppress immunity. We were using them to be able to actually work alongside with the cancer to be able to kill the cancer, but also to use it to be able to actually enhance the immune system. Okay, very important. So this was not just a conventional chemo getting FOLFOX, but we use some of those data to be able to actually make sure that they're being directly injected. And this is our other chemo immuno precision injections, directly injecting those chemotherapies in those areas, but to also directly inject immunotherapies to enhance the immune system's response systemically to the body. Because I also have to tell you that even as bad as that imaging looks, there's also disease that's not being shown that's in a tumor, that they're micrometastatic disease elsewhere in the body. So your immune system has to be able to be the one to be able to be engaged to target it. Now, the other thing that we also see is that we also added in adjuvant targets. These adjuvant targets also enhance the actual chemotherapeutic effect to be able to make sure that the chemotherapy that's being given has the desired effect that we're wanting it to, and it's enhancing its kill and supporting its immunotherapy actions. The other thing we see with this is that we were delivering precision targets of other smart drugs as well. These are non-chemotherapies, that they're smart drugs to be able to actually enhance the actual mechanisms that we're looking. And then we also use some off-label use medications that we're actually showing to be able to be supportive in this actual patient's case. They're not chemotherapies, but they're other medications that enhance the chemotherapeutic mechanism, or it also enhances the ability of the immune system and enhances to slow down that tumor as we're able to actually deliver the kill.
Yeah, and what I really want to show here, which I think is very helpful, I just want to bring in this idea here because in pancreatic cancer,
Oh, this is colorectal cancer.
Yeah, I'm sorry. I apologize. In colorectal cancer, which is true in colorectal cancer as well, you don't usually get um, direct injection into the tumors with immunotherapy, genetic targets, and then the adjuvants in combination to create a systemic immune response. The reason this is important, and I apologize because I was looking at slides while you were talking so I could help explain this. With colorectal cancer, when it's spread like this in these different regions, you need an immunotherapy response in our clinical experience. And there is no, besides using maybe a PD-1 off-label or if it's available, there's really no good. Well, we create inside the tumor an immunotherapy response that creates a recognition of the body's immune system to go after these other metastatic cells in the body, these cancer cells. So here you see this image, and you can see that the catheter, the size of the hair, is entered into the tumor. And then into the tumor, you see the genetic chemo, which has been targeted. So we've confirmed the chemotherapy that is going to be best selective and best immunotherapy targeted to the patient. Then we've confirmed the immunotherapy agents that are going to go into the tumor to express the antigen to create an immunotherapy response. I mean, and this is just level one. Envita can actually take these natural killer cells that you see here in the image, or even dendritic cells, and grow them, type them to, customize them genetically to the patient and to their tumor type, and then give it back to them in our international facility. So we have different levels of immunotherapy, but here you can see that we're doing this targeting. Why? Because as you look at the imaging later, I want to show that it's not just the chemo. Even though the chemo was given in microdose in the GTFC, genetically targeted chemotherapy, it's so low dose because we know the targets are spot on, but they can be nano-delivered in microparticles, so it's easier for the body, the patient's quality of life. They don't have the same severe side effects that you have in standard because of the dosing. So I want to bring that all in. And this image, the images for me, I'm a very visual person. It shows, you can see what's happening here that we can't explain by talking. The green is the antigen. Now you're giving the body information. The immune system, the natural killer cell here, the little spiky object, picking up that information and spreading it to the body, and the body saying, here's where it is, because it's not just in the bone or in the lungs, or it's moving at a micro level everywhere, and you can't see that, but the immune system can identify it, seek it, and do its proper job, and really just kill the cancer. So I just wanted to bring that up because I think it's so important when we oftentimes think of, we're going straight to the tumor. What does that look like? Because oftentimes patients might say, well, I can't visualize it. Well, now you can see it. Okay, let's move on. Now here we're looking at the CEA 5.3 John, Dr. Oertle, go ahead, continue. And
yeah, so we're seeing, so the beginning of treatment, we're looking at the right hand of the screen. And this is the data points as we're seeing ongoing. Very common. I want to just draw the attention. Again, it's slightly bumped up from that, from the first level to the second therapy. That's common when it comes to immunotherapies. You see a slight bump or a continual bump. And then you start to be able to see a drop. This means that the body is responding in a favorable way. We're starting to see that CEA return to a normal path. And this is only just after a couple of months. So this was, again, the body learned it. It started to see some bump and then started to be able to actually respond. We got really excited because when we start to see this as well, it means that the body seems to respond. We have other markers that we track and monitor with this as well. So we'll continue to keep going on.
Yeah, but you can see that 5.3 down to 1.2. That's very nice. Okay, continue.
Yeah, so these other markers, as you can see too, some of the actual, the cell-free DNA that I was talking about.
Genetic markers.
Genetic markers of the cancer that are floating around in the bloodstream. What did we see here too? We're seeing that, again, they lead to prognosis. They see when they're dropping, you can see an elevation when you have some die-off. So it's important to actually understand what's happening with them. But in this case, we just saw a drop and we were very happy with seeing this. And we thought, we're going to see a great image that goes along with this as well, because we're just seeing that everything started to be able to drop.
Well, here you go. Picture's worth 1,000 words here.
The picture is worth 1,000 words. So what you were talking about, Dr. Prato, was that when we inject those one to couple lesions, that's helpful, but it doesn't just kill that one in that lesion, that tumor that we injected. It's giving the immune system information to go off and to be able to actually seek out other cancers, other cells elsewhere in the body. As you can see right now, what you're looking at, on the left-hand side is the initial image that we saw with all those black spots are all the areas where the tumors are at. This is called a PET scan. And what you see with a PET scan is that there's a radioactive isotope, often called contrast, that's injected, and it goes to where the cancer is at. So you can actually, it lights it up like a Christmas tree. Both of those radioactive isotopes were delivered in both of these scans. As you can see, the left, you see a lot more disease burden. In the right, you're seeing it look so beautiful. Those dark cancer black spots are almost completely gone. Now, there still is some, you can see it's less dark if you can see on the right side. It looks beautiful, but there still is some activity that's still there. And this is where we continue to keep monitoring. All the tumor markers, the DNA looks much better, but the immune system has now recognized the ability to be able to go after that cancer. And this is where then it goes into a phase 2 in our treatment protocols, where they go into a home care response to where we continue to monitor and we continue to be able to support and manage.
So here's what's important. I want patients to see this. So this is a great response. You're seeing a patient responding well, but we're not done yet. There's an ongoing process where patient will get this nice response and we're monitoring, and there's compliance. They may have to come back out for specialized if they have a target that we need to provide for them, but it's just brief. And you'll see that we've had patients where then it's next month it's better, 6 months, but you start seeing continual improvement because we are managing it with all of the genetics and targets. So we know where it's going. Now, this is a widespread disease that is becoming a manageable disease through precision. That's the beauty of precision oncology, and that's where we hope we actually have some really brilliant technology coming at Envita that continues to help us take it, I always say, to the next level. Our goal is, by the grace of God, we want to be able to provide this for all our patients, get them well, get them home so they can be with their families and do the missions that they have in their life. So that's why we're always moving to outcome. Outcome is our goal, and technology is getting there where we're able to get better and better at targeting and organizing and basically helping these patients improve. This is just a final image. We don't need to go through this. This is just a summary. I want to bring it up. This just shows all the resolution, significant decrease, resolution. So you see the patient here is responding well to care. And if I bring the image back up, you can see here clearly how important it is. So today in colon cancer, you don't have standard immunotherapy, you don't have standard genomic targeting, you don't have integrative adjuvants, you don't have on and off label, you don't have it delivered to you in a custom algorithms of Envita's GTFC or its interventional radiology oncology, or I can go on to our immunotherapy custom, where we take the immune system of the patient and custom build it to grow and expand to kill the natural killer cells so that they can go in. I mean, this is the advent of medicine that's continuing to make oncology better and easier to treat, but you just can't access it. This is the problem. It's not available. And as we keep moving forward, I've been surprised because we've been on this track for several decades, and I'm hoping oncology as a standard is very slow to adopt new technology, as our insurance company billing and on and on. It just stops people to have access to the latest technologies. This is a great case, and this is good one to watch. You can see how we're treating, monitoring progression over time, and we have colon cancer patients that are alive many years later. Many years. The longest one is 20 years. He was one of my first patients in the early days of Envita. Of course, we didn't even have all this technology then. We had what we could do then, and it's just evolved and gotten better. And we have a number of patients that we treat this way. But it's important that I say to the patients that precision is different for every patient, and that is the key. That it needs to be targeted and monitored and watched, and then and just continually improving that precision can make all the difference. Well, listen, thank you for joining us, Dr. John. You have something you want to add? Go ahead.
I do. One thing I want to be able to close with as well is that this case, she was feeling good throughout the course of therapy.
Yeah.
This is so important, and this is what's really important with Envita Care, with the actual precision technology and the therapies that we have, is that this is not a high dose, maximum dose chemotherapeutic regimen that's going to present with what happens usually with our 5FU, those full FOX regimens. The oxaliplatin is usually a lot of neuropathies and a lot of side effects. Potential for even kidney damage as a result of these therapies. And this is where it's so important that when we're using these algorithms, the patient is feeling well. Yes, you're going through therapy. You're killing cancer, but there is a level of you're feeling well and you're getting through this. This patient had her bell ringing ceremony, and it was just beautiful to see the joy on her face and the excitement to be able to actually present. And so as a result of that, again, it's one of those other areas where it's just so different than anything else that's being practiced out there. And it's a great joy that we can deliver this, because it takes a lot of work to be able to deliver precision care, and not many people are having a robust infrastructure to be able to provide it, both on the conventional side or on the integrative side. But it's just such a joy when response.
A lot of people don't know the origins of Envita and how it's been around for 23 years, but I can tell you, because I've been here from the beginning, by the grace of God, we have continued to pray, work hard, and we've been given innovations and technology and the way to combine it and the way to bring the teams together, and we have compliance officers from the medical side to the pharmacy side, and to bring that kind of care isn't easy. It's not an easy process, but it's worth it, because when you continue to get patients to have responses that are positive, it's just it's so joyful to see, and the quality of life, to do it in a way that is not harming the patient, but giving them quality of life. That's the goal of what we do. That's the goal of our work. Well, listen, I want to thank you for joining me, John, again, Dr. Oertle, on another case history, colorectal cancer. And for those of you who are joining us, I want to wish you the best in your journey to healing, by the grace of God, that you're given the wisdom and direction to get the healing that you need. And we're here to help you in any way that we can. And I want to wish you, again, the best in your journey to healing. And again, God bless you and your families. And we're here to help you with anything that you might need. Any questions or whatever, we're here to do that. We've been doing it for 23 years. So thank you for joining us.